My name is Kornogard, and the purpose of this video is to show that at the same time you can have happier customers and document your quality. Happier customers meaning that patients and their relatives will be more satisfied with the service you deliver when they are being treated for a disease like breast cancer. And document the quality means that you can avoid making errors and you can prove it. And if anybody challenges that you have made the right decision at any point in time, you can document that indeed you have made the right decision given the information you had at that point in time. What I'll show you is that is first 3 videos with breast cancer survivors who I think would have appreciated to be able to see their own treatment in the same way as they're used to when they order a thing on the internet, where they can track the parcel as it goes through production and delivery. And if they use a GPS to go places, they can be assured that they are advised to go the right way to that destination. So now that is possible in healthcare as well. And I will show the 3 videos that they would appreciate if they had this kind of solution. And then I will show how the technology works and why it is now possible to unfold a treatment plan and devise it to anybody involved, also the doctors. And finally, I will show why this technology can automatically document that you made the right choices. So let's start with the kinds of testimonials that will show this to you. And we will start with this breast cancer survivor, and I'll switch on the video here, and you can Google it yourself on YouTube, breast cancer survivor stories.
To me, that is very important because there are subjects or information that's shared during those conversations is very relevant to what I'm going through as a cancer patient. There are a lot of experts or doctors or care providers who come and speak or share their knowledge and experience is something that I'm looking firsthand. So instead of going and buying a book or trying to read online and not knowing if I'm getting the correct information, coming here once a month, being with others who are going through similar breast cancer or other cancer treatment like I am, being surrounded by them and sharing our experience, laughing, talking, along with a cup of coffee, and at the same time getting all the information that is pertinent to my treatment or something I may have missed, I may have not even known. All that information that they provide is vital, and I look forward every month coming and being part of this Coffee with Conversation.
You might notice that what she said is that she appreciated the information that got shared. And if she hadn't got that information shared, she would have looked online. I think that we can't prevent that people look online, but at least we can put everything in context so that we can enhance what is told by conversing with doctors, etc. We can enhance an online presence of the whole treatment and make sure that this is completely in line with what you are being told in those meetings. And that is something we then provide as a supplement to all the other channels of information. Now we will switch again. So to the next video, and I'll have to move to a particular point, 440 here.
And so I was scared because I didn't have answers. And once I got the answers from Mayo, then I was at peace with everything, what was fixing to happen to me. they gave me a plan of what they were planning on doing, and I was like, okay, let's do this. I also have, two other friends that also went through breast cancer at the same time I did, and we all had the same type of breast cancer. So I already had a support group, and we would just talk and ask each other how we're doing and what's going on with your treatments. And so I really do think that having other people, talking with other people who've experienced the same thing as you, just kind of makes you feel like, okay, I'm not alone.
Now you will notice that what she said is that she was scared until she had answers to her main questions. And she very much appreciated that Mayo Clinic, the hospital that treated her, gave her a plan. This again suggests that there are a lot of things you would really want to know, and you might be told, but you have to have it told again. Getting a plan is something you would appreciate. She also says that it is important to have a support group of other people, but here's where we need to be careful, because if somebody you know doesn't necessarily need to have chemotherapy, then you might think that in your case, you can also deselect chemotherapy, but your cancer might be a little different. And therefore, it is very important that that plan constitutes something that is pertinent to your case and not in general. Let's switch to the third video, and let's see if I can do that. It's a man who had male breast cancer, which is not at all rare. Male breast cancers or breast cancers hitting men happens in 1% of the cases. So it's not a very rare disease. But let's hear what he has to say.
Healing will follow. The other thing that I would tell people is, and this is a big one, I tend to be very self-sufficient, but you really want to have a support person come to those appointments with you, because there were times my wife would say, oh, she said this, and I wouldn't have that in my notes just because there's so much. And so having a good support person to both be there for you, but also attend those appointments is really helpful. I'm a very private.
Yes, the key thing he says is that it is important to involve a support person, but he also says that there's so much information flowing around. He was actually lucky that his wife captured it, but it is very important to get that in writing, because there's so much information that that should be in writing and which is important to know, which is given orally, but if you don't notice it, you might not have it in writing. So all these three breast cancer survivors, I would say, would have appreciated if they would be supplemented with a tool that helped them understand the treatment and the kind of path they would have to go through. So what I would like to show you is such a tool. And the point is that we have developed a tool at curegps.org. You can actually try it out yourself, and it's on the web. But what it does is it maps out a complete treatment plan in your case. So one of the things you would get at several points during the path of the treatment is a report like this, which would capture all the information you have supplied and all the decisions the tool has recommended and the decisions the doctor has then taken or you have made them. So here you can see that this is a female. She still has periods, etc. And you can see all the information that you have either supplied or that we derive from the cancer treatment. And you see basically everything. And at the bottom, you'll get a lot of documentation. We'll come back to that, which pertains to your particular case. and then a timestamp, October 27. And the way it evolves is that at a certain step, you select who you are and in what country you are. It might be hard-coded because if we make a solution in the US, you don't have to select that you're in the US, but this is a general tool. So you have to select the country by which you want to conform or whose guidelines, or the guidelines of which you want to deal with. We have selected the US, and there's a short description of what rules have been are in place in that country. They are a little different from all the other countries. In particular, the Danish rules are very different. The UK rules are different as well. The Israeli rules are different. No, they are similar to the US. Sorry, but I've selected the US, and then there's a lot of things. The check marks show you what you have done up to now, and the non-check marks show you what you are supposed to do. You don't have to do it in that particular order, which we have here. You can find something checked later if it is done already. So it's just a suggested sequence of activities. The point is that there are many things happening here. And one is the accumulated patient record. The other thing that might be of interest is which surgery you have. And this tool will actually document everything. In this case, it documents that the breast conserving surgery or lumpectomy has been recommended, and it will also document that as a patient you have indeed chosen that surgery procedure. But the point is the recommendation might change. If you had radiation therapy in the past, it will recommend a whole breast removal or a mastectomy. And this is also the case and that's because if you had radiation in the past, you would have to have it again if you had lumpectomy, and you can't have it twice. So you must have mastectomy in order to avoid having it again. Also, if the tumor is not well delineated, then the doctor has to recommend a mastectomy. You may still choose a lumpectomy, but then the tool will document that that was your choice and it was in conflict with the recommendation. And the doctor can actually choose to recommend something different, like recommending a lumpectomy, where the tool would mean that the doctor should have recommended a mastectomy, etc. And the point is, it guides you all the way, and all the decisions are documented and recorded in point in time, all the way through the treatment until you get to the end. And at the it deals with a lot of data on the way through, and it has a server error because it has a lot of data here. But never mind. The point is that this tool I'll now explain. And the way it works is that it handles all the decisions to be made, and there are decisions at the diagnosis or immediately after the diagnosis, and the decisions to be made throughout the treatment. At the diagnosis, you have to deal with all the decisions on the left-hand side, staging medication before or after the surgery, receptors have to be set, the lymph nodes have to be assessed, the genetics, counseling has to be carried out, the tumor has to undergo a biopsy, and from all this you devise after the surgery a certain treatment plan, which might last for 5 to 10 years after surgery. Then the treatment goes ahead. You have the neoadjuvant treatment, which means you have medication before surgery in some cases, because if the tumor is big or there are other things involved, then it requires an immediate medication, or that you learn from the medication which medication elements will actually work on your tumor. Then you have to give the medication to see what actually works on the tumor before you remove it, and remove all possibilities for seeing what medications work on you. That's neoadjuvant treatment. And there are a lot of other decisions to be made, surgery types, analysis of tumor, and from this you configure the adjuvant treatment, etc. And the point is that all of this is a complex problem with a complex solution. So we have divided all kinds of workflows in 4 categories, as you see here. Workflows being good for approval workflows, but we have opened the 4th quadrant, upper right-hand side of this diagram, the so-called treatment quadrant. We've opened that with a technology, and so far there was no technology in this quadrant, and that's where all the cancer treatments are. That's because a cancer treatment involves that the doctor, not upfront, but during the treatment, sets 300 decision variables, and that the setting of those variables or the values they have will determine more than or around 250 activities. So the 250 activities that you see on the left-hand side, top left, are the number of steps you have to go through before you're cured. And the 300, the number 300 you see on the bottom right, in green, are the number of variables. Just to give an example of what these variables are, you see them in green here. So the breast cancer treatment is a combination of those blue arrows on a high level. There are lots of other combinations down below them. And the way they are combined, or the configuration of the treatment, is determined by the 300 variables, which are summarized in the green boxes. And that is a complex problem with a complex solution. The 300 decision variables are, for example, 1, is it a man or a woman? 2, if it's a woman, is she then menopausal or not? 3, if she's premenopausal, is she then pregnant or not? Is she or he young or old? Did she have radiation in the past? Does she have a family risk that is high or low? Does she have any drug allergies? Then there's a list of preferences, yes or no. Is the cancer big or small? Is the tumor a single tumor, or are there multiple tumors in the body? Is it invasive or not? It's a breast cancer, so is it ductal or lobular? That's the position in the breast, for women at least. Is it grade 1, 2, or 3? Is it estrogen receptor or ER positive or negative? Is it HER2 positive or negative? Are the lymph nodes hit? And as you see, these are less than 20 out of 300 decision variables that can be independently yes or no, most of them. And therefore, there are 2 to the power of 300 different ways you can combine the treatment. And that's why nobody has made a configuration tool before that allows the patient to see what out of the 2 to the power of 300 combinations, which one is mine. And that's what we have in the Cure GPS, we call it, because we think it is similar to making a route plan in the GPS when you have to go places where you haven't gone before. So it holds an unlimited number of variants, because the technology which I'm about to show you will grow linearly and not exponentially with the problem size. And that's why it is now possible to devise a solution to a complex problem. It represents the solution as a project plan with start and end dates and a lot of activities, and the problem and thereby the project plan can change as you are going through it. And that is another reason why it hasn't been done before. The oncologist, or the one in charge of the breast cancer treatment, has to, at a high level, make a lot of decisions, but at a high level, it is very important to make the decisions shown here. meaning which are the activities we have to put in place to treat that particular patient. 1 through 9. So 1, is it necessary to have a new adjuvant upfront activity, meaning that you have to devise medications before surgery. And that you have to do if it is a large tumor, and this is overly simplified, so I've just put large, which is the main determinant, but there are a lot of other variables that go into this decision. But if it is, yes, if it is large, you have to devise new adjuvant treatment before surgery. Surgery comprises steps 2, 3, and 4, lumpectomy, mastectomy, and lymph node surgery. And you can see that lumpectomy comes into question if you can say no to the family risk, and mastectomy comes into question if you say yes to family risk, or if it is a large tumor. And therefore you have only one of the two. But which one you have, no matter which one you have, it will have to wait for new adjuvant treatment to be finalized if it is there. And that's why in the predecessor column here, it states that we have to wait for activity 1, and then the software tool enforces that predecessor only if 1 is in the plan. And the S's mean that if you have lumpectomy, for instance, there are 2 S's because at the point in time when you have that lumpectomy, you will determine whether N+ is if there are any lymph nodes involved, and then the breast conserving surgery will be set. And if you have mastectomy, the lymph nodes will be set as well. And then if there are any lymph nodes that have been involved, you must undergo a lymph node surgery, which will have to wait for 2 or 3, whichever is there. So that's the surgery. Then we have the adjuvant treatment. And there you can actually see that if it is a premenopausal woman and the cancer is estrogen receptor positive or ER plus or ER positive, if both are true, then you have to devise tamoxifen. Whereas if it is an ER positive tumor and it's not a premenopausal woman, you have to devise aromatase inhibitor followed by bone loss treatment. So again, they are mutually exclusive at any point in time. And they both have to wait for number 7, which is the chemotherapy. And if it is there. And the chemotherapy is there if it is a large tumor, or she is premenopausal, or and if it is a HER2 positive tumor, in which case you also have to have trastuzumab in the treatment plan, but not if the recurrence score is low or high, I don't remember, but that can contradict the whole decision. And yes, if the lymph nodes are involved, you must have chemotherapy. And this is a more complex rule than and or, but we can hold it. So I've just written complex because it is a rule that depends on the outcome of those variables. And as you can see, the chemotherapy just has to wait for the lymph node surgery and all the other surgeries to be completed before it can start. Whereas the trastuzumab, in principle, also just waits for the surgery to be completed before it can start. But in some cases, it waits for some of the chemotherapy, because if there's, I think it is called a taxane, which is one of the 3 components of the chemotherapy, then you have to await the completion of that treatment before you can start trastuzumab treatment. So it might have to wait for some of the chemotherapy to be completed before it can start. So the predecessor is a little more complex than just 4. It's a part of 7. Whereas the radiotherapy has to wait for the chemotherapy to be completed before it can start, and it comes into play in case the lymph nodes are involved or you have a breast conserving surgery. So this picture that you see here is in the head of the oncologist and is a high-level decision matrix for how to configure the breast cancer treatment flow. Which elements does it consist of? So just showing it because what I'm about to show now is a method called the process matrix, which makes it possible for us to hold that complexity and deliver it as well. And that you can't do with a flowchart. But the benefit of a flowchart is it is easy to understand, and therefore I have picked a very simple workflow, which can be depicted in the flowchart as a way to describe how the process matrix works. So what you see here at the top left and the bottom right are two identical workflows consisting of 3 activities. Activity 1 is called paraclinics, activity 2 is called surgery, and activity 3 is called medical. And you have to undergo surgery if it is serious, and if it is not serious, you have to undergo medical. And the same thing is shown here in the process matrix. So we just choose to say that we depict it as a matrix, what you can also see in the figure. This is another example, a little more complex, and still you can depict the workflow both as a flow chart and as a project matrix. And here we actually show that each step might have a form, which is in red, and the process matrix makes it possible to also generate the form from the data model. So the point is, for simple workflows, you can choose between process matrix and flowcharts. Flowcharts might be easy to read, but a flowchart quickly explodes in complexity when the problem becomes complex. And that's what a cancer is. It's complex. So if you want to model the treatment of a breast cancer, you have to choose a process matrix. And that is what we have done. The point is each row is an activity. So you see a lot of them collapse here, and one expanded, one phase expanded, and there you can see the activities of this phase highlighted here in red. There are 250 different activities or rows. There are several more than 250. There are 250 in any particular breast cancer treatment, but the totality is, of course, larger, from which you have to select. And then there are 300 decision variables, and each decision variable has a column in this matrix. And the way these, as you saw in the previous graph, the value of decision variables will determine which activities you have to choose, and then the predecessors will, similar to the arrows that you see in the flowchart, will tell you when you have to wait for something else. And then the decisions are made on the basis of data, and there's a decision variable saying which, for instance, which surgery type we recommend, and the rule behind mastectomy recommendation is the one you see here, inserted here. So you can see that the recommendation of mastectomy depends on several things, one of which is your family history, one of which is whether you had radiation previously, etc. And if they are true or false, whatever, if that rule evaluates to true, you have to recommend a mastectomy. So it's also in the process matrix together with all the other things, so that we have one comprehensive and composite format into which you can specify everything that relates to the treatment and then execute it in a tool like you just saw previously online for the patient. And in that matrix, we have extracted some of the knowledge that we have specified in that matrix. So it's listed here in terms of headlines. And so if we dive down in each item, I'll pick a few. So we'll take the bracket test first and dive down into it. And you will see that inside that single activity, there's actually a lot of things going on, which means that if your bracket test is non-existent or negative, we have to look into your family history in order to assess whether there is anyway an elevated genetic risk involved. And that the example shown is that if your mother had breast cancer before the age of 40, she was 38, then you have an elevated risk as well. And there are other combinations of family history, and it's all captured in that single step. And then there's the tumor characteristics, which you often get from a mammogram. And you can hover the mouse over the eye and see what the background is for choosing anyone. It might be filled out if it is read from a system that has that information for you, or you can supply it yourself, or your doctor can. And if it is an invasive ductal carcinoma, then ICC is selected in that, and it will use that subsequently in the treatment plan. Then it summarizes what kind of surgery you should have, and then it records what you choose as a patient. And finally, it will also find out whether you need to have medication before surgery. And there are other things determining that than just the size of the cancer. You can see them highlighted in red. It then goes on and configures the adjuvant treatment, chemotherapy, radiotherapy, hormone therapy, etc. And you can see that it summarizes that. And if we go through it step by step, in order to make that decision, you must have a pathology report. And again, it might be read from the system, or it is typed in by the doctor or somebody else. And here you can see that the estrogen percentage of cells reacting to estrogen is 66. And if it is 66, which is more than 10, which is the threshold, it is said to be hormone receptor positive or estrogen receptor positive. And we have also in the pathology found out that it's HER2 negative, and then it deduces from those numbers that it is ER positive, HER2 negative, and it's grade 1. So that's just the summary of the pathology report. And since it is ER positive and HER2 negative and grade 1, a gene test comes into play. For instance, you could select Oncotype DX, and based on the outcome of that test, it will determine whether it should recommend you to have chemotherapy. The test is such that there's a recurrence score, which says that you will benefit from chemotherapy, and therefore we will recommend it, or the tool will recommend it. Since it is recommended, it's also offered, and you can see the check mark here says that, and the doctor doesn't have to do anything. It will be set automatically by the tool. Only if the doctor disagrees with this recommendation, he can alter that selection. And if we offer chemotherapy, then the big question is, will the patient accept chemotherapy? And it records that as well. Since it's HER2 negative, biologic therapy or trastuzumab or Herceptin is not offered, and you can see why. And therefore we skip the step called trastuzumab tolerance, which is an ongoing follow-up on the heart to verify that that trastuzumab is tolerated during that year, which is used to give it. Finally, there's a radiotherapy because that patient has chosen to have lumpectomy or breast-conserving surgery, and therefore the radiotherapy is offered. And we strongly recommend that you actually choose it, but we can separate the recommendation from recording the actual choice. And if you hover the mouse over the eye, which we have done here before screen printing, you can see an explanation of why this is offered. And the configuration maps into a set of activities. We know the timing and the predecessor of each activity, so we can see that the surgery is scheduled for the October the 31st. And since the chemotherapy has to wait for 21 days or 3 weeks, it is planned to start on November the 22nd and last for 126 days. That's 4 months, which brings us to March 28th. That's the last day of chemotherapy, and that's when the tamoxifen treatment can start and last for 10 years, as you see here. And that's also the date, March 28th, where the radiotherapy can start. And you can alter those dates if that is how it must be done in the hospital, but the tool will make sure that you don't prematurely plan for anything or do it too late. And then it carries on. This is just a few of the many, many things that this tool will help you through. And it will help the doctor and the patient to understand what the doctor says, and it will all be combined. At the end of this, it will, and that is where I got the server error, because it's a quite comprehensive step. It will be able at any point in time during the treatment to deliver and read from, deliver to an EHR or electronic health record, or take data from it. And just to give you an impression of the wealth of data, we have screen printed that one step of the workflow, which takes all the data out or reads it in. And there are some data about pregnancy and whether she's premenopausal. There are some data about mammographical conclusion and whether this is indeed a cancer and whether it's unifocal. There are some about your lymph nodes. There's some data about staging and which kind of surgery you have been recommended to have and which you have chosen. There are some steps or data elements about which adjuvant treatment elements you have chosen to have and which are offered. There are, since you have been offered a chemotherapy, there's a combination of chemotherapy that you have to select, or your doctor would have to select, and that is probably dependent on either the new adjuvant treatment, where you get to see which works, or a genetic makeup of the tumor. And there's a lot of other data on medication, and then there's a recording of which information you have given out as required by the guidelines. The patient can choose to take it off, so the patient has the final say on whether he or she has actually received that piece of information, and it might be important for you to have told, and this is the way to verify that the patient has been told about this for later disputes. Then there's excuse me, there are some personal data, and there's a weight and body surface area calculation, and from that and then there's comorbidities that you might know of. It might be read from the EHR, or you have to ask the patient if that patient suffers any of these diseases. And then there's a lot of other data. There's the pathology report output, and then there's a calculation of the doses for one of the chemotherapy agents, cyclophosphamide. It's body weight dependent, so the kilograms are in the system, and then based on those, the tool will calculate the correct doses, so we don't make any doses fault or error here. And the two other out of 3 agents in the chemotherapy combination are dependent on the body surface area, and therefore the doses must be calculated based on that, but that is also, as we saw previously, in the tool. So the tool will, as a closed system, calculate the doses correctly. And finally, it will devise the radiation therapy and tell the radiologist which doses to apply, and you can put rules in there for that as well, and make sure that you don't make any errors in that compartment either. And the point is that putting all this together and handling it and changing it as it might develop during the treatment, then the patient can be happy, can remain as happy as possible, as you just saw in the videos, in that this is a secure way to communicate what is going to happen and what has happened and why throughout the treatment. But the point is that this person, the doctor, can also use the tool because it prevents that doctor from making any errors, and it documents that. And the reason why it documents that is that behind every decision, there's a rule or a Boolean formula saying, should you recommend it, yes or no? In case of lumpectomy, you've already seen that it relies on a lot of input, and the rule that you have or that you use in this tool is recorded in the tool itself. So you can actually see that certain things make you recommend either lumpectomy or mastectomy. And the data is also recorded in one big XML matrix in a database. And you can actually see that then it records that you have recommended lumpectomy and it was chosen. And then it timestamps all that data as well. So you can verify that up to that date, you had this particular set of data, and applying those rules in combination with the data, you must have come up with a recommendation for a lumpectomy. And that is conform to the guidelines given the data you had at that point in time. So that if you had other data later than the actual decision, it doesn't influence the decision because it was already made. But the tool then handles all those going back and forth. So for instance, if a body weight changes, which is quite likely, the doctor will have to update the doses of the chemotherapy during treatment, and the tool will remind the doctor to do that, so that it not only makes sure that you make the right decision initially, but at all times, and also based on when data changes. So we hope that you agree that this tool will dramatically change, and to the better, the way you see your own treatment and the ability you have to involve loved ones, which have maybe a cooler head than yourself, into supporting you making the right decisions and understanding those that the doctor has made, and understanding the treatment all the way through to the cure. And at the same time, that doctors will be able to document that indeed they didn't make an error, and they gave the best treatment they could, and one that was conformant to the guidelines. So we look very much forward to working with you on this, and thank you very much for listening, and yeah, looking forward to the business of improving healthcare, starting with breast cancer.